a virtual blended discussion experience. So bear with me. We're going to try and experiment a bit with how's the best way to do it. What I'm going to suggest is that we're going to have to do the hands thing. So you're going to put your hands up, and I'm going to ask everybody that is in participating online to also use the hand chat button. And then I will take turns between the group as well as the, I might need a piece of paper. Well, let me see how it goes with memory. So let's start just with this room. Is there anybody here who would like to have a comment? And the comment can be on anything from this morning's discussion. Russell was already jumping up and down earlier. Russell, would you mind just stepping to four? Yeah, unfortunately, you're going to come and stand next to Mark here. And we're going to come and just so that we can pick you up on the mic. So if you come and stand here between me and Mark, and excellent, great.
What's my board members? I'm going to have to do like
So you can just go, yeah.
Can I go? Thank you. Well, COVID for me has been a big eye-opener about very different aspects of South African life. You know, I think we saw a whole lot of different things colliding, right? And in many ways, we saw the limitations of a rights-based framework, because rights are afforded to everyone, not just to the privileged. And when we look at some of the data that came out of the system, you know, there were a lot of things that raised red flags, right? So the NICD publishes a weekly hospital surveillance report, right? And it tracks about 600 hospitals or so, public and private. And it looks at admissions. And we look at the split. So 15% of South Africa's population is covered by the private sector, right? The average cost for a COVID admission in the private sector was around 160,000 rand for a 10-day period. I think that's according to Susan Cleary and others at UCT that did a cost effectiveness study. In the public sector, we worked on around 70,000 per patient. So that's on an average 10-day stay. But when we looked at the actual admission numbers, you know, close to half of COVID-related admissions occurred in the private sector. Right? When we looked at testing, 60% of tests were conducted in the private sector. Right? So, but despite us having the power of this, what we call disaster management regulations, where we ban chicken and just about everything else, there wasn't a single regulation that looked at a unified health system response. And I think the question that I'm raising is, have we got to a point now where just saying that everyone has access to healthcare services is enough to address inequality of access? You know, Di McIntyre and John Atakuba did a report in 2017 that looked at healthcare utilization in South Africa and who utilized healthcare services where. The vast majority of our populations access healthcare services at primary healthcare level or at the primary healthcare district, first hospital or referral. In COVID, we had a total turnaround of that, right? Most of the care was hospital-based. Most of the investments that were made by the system was at the hospital level and to the detriment of primary healthcare. One of the things that I found most chilling, for instance, was access to diabetes. Diabetes was the leading comorbidity amongst people who were admitted to hospital, right? And to this day, we don't routinely collect diabetes data. That's despite like a prevalence rate, a model prevalence rate of around 10%, right? With only 1.5 million people in care versus 5 million people potentially living with diabetes. But I think the real challenge for the rights for me, without explicit prioritization, right? The healthcare divide is going to become wider. So I don't think just looking at Section 27 is the only way. We actually have to look at limitations to the right, to the extent where we prioritize the 80% who are reliant on public health services. In addition to that, there's also inequity in the flow of funds within the public sector. 60% of public sector funding is spent at the hospital level. And it's the level that's least accessed by the majority. Right? So when budgets get squeezed, the ones that get squeezed the most are the ones that are in direct contact with frontline patients. So how do we change or look?
The sound is just a little bit.
Oh, how do we look at our legal framework in a manner that starts addressing the challenge that we face in South Africa, which is one of poverty and inequality. Right? 80% of health outcomes are achieved outside of the health sector. Right? So the things that Mark spoke about in terms of a basic income grant is a massive advance, right? Because it raises household income levels. We have better educational outcomes. We have better nutrition. There's so many different things that intersect. But I don't think that the time of just relying on a constitutional provision that affords rights to everyone without considering some kind of explicit prioritization, and in sometimes also taxing of the private sector to ensure that we have better public provision. So this is not just the responsibility of the state, right? The state has the responsibility to create the regulatory environment, but we saw with the HMI, it was delayed for months because of a legal challenge, right? So the law of contract is often the strongest law in the Constitution. So yes, we have a constitutional framework, but as activists and as practitioners, I think we need to start looking at the extent to which having a rights-based framework either limits us or allows us to expand the kind of access to care that we need, that prioritize those that need it most. The last thing I want to leave you with, over the last 5 or 6 years, we've seen primary healthcare utilization go down. Right? We created the universal health system or the health reforms in the 90s. We were averaging around 3.2 visits per year. Today, it's just over 2. And that's not because people have got healthier, right? Part of that is because as the health sector, we focus sometimes too much on the health treatment aspects and not the broader determinants of health. And I'd like you all to read Steve's paper on the critical realist framework on the rural determinants of health. And think about how do we need to use the legislative provisions that we have, and how do we make our advocacy and activism much more intentional towards achieving a result rather than an ideal. Thank you.
Thank you very, very much. We're going to take Steve Reed would like to speak. You can unmute, and so if there's anybody else who wants to contribute, just put your hands up and I'll recognize you. Steve, you're live. Oh, there.
Thanks. I don't know if you can hear me, but I'm going to go ahead and just respond to Mark's speech. And thank you very much, Mark, for very comprehensive picture, which is useful from outside of our rural health framework, I think. And the question follows Daniela's comments in the chat before the break about, how do you tackle this elephant? What you gave us a list at the end of what you regarded as priorities, but how do we prioritize those, because they are at different levels of the system? And there's one set of priorities for practitioners on the front line. There's another set of priorities for managers at hospital and district level, and there's another set at the provincial and national level. So just in thinking through the many different responses to the gap between policy and implementation, are we able to put some things higher on the list than others in our efforts at advocacy, and maybe even activism, if you make a distinction between those two? Thanks.
Thank you very much, Steve. That's great. Anybody from the floor? Yes, please. You need to come to the front and you need to take your mask off, because otherwise nobody can hear. There we go. Please join us. Just introduce yourself.
It's Victor Fredland. Thanks, Steve, for your comment. And I think Mark's presentation was very encouraging. We need to take people need to take different aspects for themselves, I think, as well. I don't think we can expect one person to take all these priorities. But I think what we're challenging is everybody needs to be activist. And we need to divide up the task. So it is a big task, and that's why we need to divide it between people. One of the things that we did in the AIDS epidemic was to actually, and I did a talk at the PASA conference on it, was to actually use the challenge of HIV and the need to get ARVs to people as a tool to build our primary healthcare network. And I think we've missed a lot of that opportunity in COVID. I said that at the beginning. COVID is quite a high percentage of the population. Why is our major tool, the high percentage interactor, not geared up to deal with it? And you know, again, it begs the question. Those frontline workers should have been the first to be prepared. And much of the action is not actually high-tech action. A lot of the basic action would save many more lives than that ventilating a patient for 3 weeks or 6 weeks. But if you actually gave high-flow oxygen to your patient at the clinic, you might have a better survival rate. What are we doing to use any crisis that we have as a good opportunity to build? And we need to keep our minds on it every time we face a crisis. Don't waste a good crisis. Use it to build something better for tomorrow.
Yeah. Thank you very, very much. So we have Paul on our online, and then we'll have Desmond after him. And Paul, can you unmute yourselves and contribute?
Afternoon, everyone. I don't know if you can hear me.
Loud and clear.
All right. No, thanks, Mark, for the presentation. It was very informative. But I've always been troubled by the Section 27, because I feel like there's always that loophole, more especially when it comes to rural health, where the decision makers tend to use when they say they can provide services, but provided that is within what the resources that they have at hand. And this thing has been used many times. I mean, from experience, I've seen this at hand, like being practiced at hand, where some services can't be provided because there's always that loophole to say that the government can stretch to the limit of resources that is available. Shouldn't we maybe start questioning that to say which resources need to be standard? Because I feel like policies are there, as many speakers have already alluded on that. But I think we have stretched the system and we have stretched the front liners. I mean, I think one of the comment on the chat was to say, for how long are we going to keep stretching ourselves? Like, I know people who go overboard in terms of like trying to reach out to deliver the best services they can, to a point that some people, they even reach to their pockets. But shouldn't we maybe now start questioning to say, how do we change the root cause? I mean, like, there are some things that need a head-on challenge. Like, you get these delegated positions, like political delegations, in some very vital positions. For instance, one example was given that other district, they just got a memo in the morning to say that cut off a budget is this. And then there is a front liner there who is waiting for bandages and everything. So I think maybe it's something that we need to start to face it heads on, to say, this is the standard that we want. We understand that this is a right, and you can provide services up to this extent, provided these are the resources you have. But we need to cry out to say, enough is enough. This is what we want. It doesn't matter whether I'm in the rural of Mpumalanga, Limpopo, or anything. This is the standard that I want. Or else I'm not going to stretch myself further, because that's where we get the work burnout. That's where we get people migrating out of the, we have a lot of good skills. I mean, like, as the minister said earlier on, to say, even people like Prof. Luvengo from CMJ came all the way down. It's a home soil kid who came all the way down to just teach a basic skill. So it shows you that there is some way that we need to start attacking directly. And one of the things is that a loophole that they always use to say, we will provide, provided this is the far we can go. That's all I wanted to say. Thank you.
Thank you very much. Thank you for that contribution. The clearest is the guys on the online, aren't they? Desmond, would you like to come forward and please take the mask off just for sound purposes? Luckily, we're all vaccinated. Yeah, you can stop a little bit forward on.
Okay. Yeah, thanks, Mark, for the presentation. I've just want to talk to 2 points that you mentioned. The first one is, and I agree with it, that the day the activist and the politician reach the same conclusion, we'll see the different picture. So I think that is very sort of sound familiar to me to say that, of course, we need to go. But first is that I'm looking at what happened previously, and maybe that's what we should revisit to say what happened to that. Because we also mentioned that we need to start doing stock taking sort of to see how we've been doing things and how we can do things going forward. So you look at South African National AIDS Council, SANAC. I think that's where maybe the development, it was where there was a consensus to a certain extent to say, how do we solve the problem, and then how do we come together? And it was, I'm not sure what happened to it and how active it is, and what is the view of the activist in terms of at the ground level. So it's also like, I remember the project that we started, the Stock Out project. And then there was a presentation in one of the AIDS conference where we presented the findings over the province for 2 years. And then after that, the national now started the SDVS system, the drug visibility system, where there was, when we indicate to say that we need to come together and monitor the drug availability or the drug shortage. Now, the government sort of came up with a system that, although the last one were not that involved as the activist, but to a certain extent they were counteracting that. But now how effective it is, and then who monitors it, and we sort of now withdrew as the activists to say that we've mentioned it, we reached the goal, or to a certain extent now we withdraw. Now we don't know what is happening to it, and it's not active, and we're still, like Mark said, that almost 94% of the facilities, they still have drug shortage, they still have a staff shortage. So lastly is that, so that is just maybe where you need to discuss and have further conversation around it. Last is also the concept that I like is to say we need to integrate health into the community and not bring health in the community, to the community. So there I'm coming up with something to say, and that is the question that we have always asked. What is the role of the governance? We have the clinical committee, the hospital boards, the provincial council and national health council, but who do they report to? Is it a governing committees, the governing structures at all levels know their role, and are they practicing their role? Or are they just being captured to a certain way because once they raise the issues, they'll start going to the provincial council or district health council where they now meet MEC and talk with all this thing. And to a certain extent, they are not that active. So maybe we need to look at the role of the governance structure and the composition of it to say what is really their role. And I always came up with this issue of to say, can we compare our governance structure, health government governance structures with the education governance? Because if you look at the school governing bodies, to a certain extent, they have the national structure that is independent, not the chairperson is not the minister at national, and at the provincial, the chairperson is not the MEC. And when they come almost as peers to say, we are having this problem and this is how we are. So maybe that is just the thought that we should have and can discuss further on it. Thank you.
Great. Yes. If you would like to come forward, and then there's nobody at the moment asking on here, and then we'll do Herman, and then I think that'll be the last 3 speakers, because then we'll need to move on to the rest of the program. And yes, come close enough, and you can speak clearly to the mask, otherwise you can take the mask off.
Hi, I'm Kate Sherry from Marisa. 2 points that I will make as briefly as possible. We've spoken about prioritization, which is essential, and we've spoken about equity. In order to do both those things, we need data. So as long as we do that, we have to be aware of where the data gaps are. So coming from a rehab background, disability. If we rely on the existing data, inequity will continue. So that needs to be addressed. Second point, I think on the question of activism and how we do this, I agree with Victor. We each need to take our thing. A danger in activism is that we each grab our own mission and we shout it. And you get a group of activists in a room and they shout at each other. And they can't tell that they're all working for the same thing. We each need to take our own task, but we all have to relate to a shared goal.
Right, Herman. Well, Herman comes to the front. There's also on the chat a comment from Carissa about, well, let me just find it. Somebody else's computer. But asking what does good advocacy look like? And I think that's the question that's coming in. We're all advocates, we're all key to do it, but what is actually the science and the key principles of good advocacy? So I think that's something that needs to go into some of our groups. There is some advocacy discussions and also into the Indaba and into our AGMs as well as we strategize.
Thanks, Mark, for raising a lot of good issues that we need to deal with as the rural health movement. One thing that I thought we also additionally need to look at, you talked about social determinants of health and legislation that would promote, well, a healthy environment in which people live. And I think in 2016, we put a law in front of government to sign off to change the Liquor Act, an amendment to the Liquor Act. And it's just not happening. And during COVID, one of the wins was to make communities aware of the harm caused by alcohol. From George Hospital, we published a reduction of 60% of car crashes, injuries, assaults, and sexual assaults. Catherine Shu presented from Worcester, same reduction when there's no alcohol, reduction in surgeries, reduction in surgery admissions to hospital. The MRC, reduction in deaths. As the alcohol is not available, reduction in unnatural deaths. As alcohol becomes available, we get back to normal mortality rates. So, and instead of the government working and using this to implement the law that we're asking them to, which actually moving away. We've now got BP applying for a liquor license and getting it awarded. I mean, how doff is that, having liquor at petrol stations?
Thank you very much. Would you like to come forward and for our... Are you sure? We would love to hear everybody's voices. We're actually now at 3:30. I don't know if you want to have a closing remark from your side, Mark, and then we'll start splitting up into the 4 groups.
Yeah, let me just come back. Sorry. Let me just come back on a few points. The easy ones first. I mean, Herman on alcohol. See, that's an example of something we can prioritize, which should be uncontroversial amongst us. But the last I saw on alcohol, the cost of alcohol-related harm per annum in this country was calculated at something like 17 billion rand a year. Now, if you say to government, effective regulation of alcohol can save 17 billion rand, and that becomes directly related to impose question about available resources, availability of resources for health priorities. The reason we don't employ community healthcare workers is because we're told that there's not resources for community healthcare workers. But activism will show that in fact there is resources. The Constitution says progressive realization within available resources. Now, it is a constraint, yes, to some extent, but it's not as much of a constraint as you think if you do 2 things. One, show government that there are resources in various ways, and secondly, understand legally what that term means. Now, when we're talking about activism, we have to talk about informed activism. Informed activism means understanding the Constitution. Not like a lawyer understands the Constitution, but understanding essential principles of the constitution that have been established. So, Paul, you take this available resources thing, for example. Government can't just say, we don't have resources available. The courts, the Constitutional Court has already said, if you have a policy, you have to have a budget. If you have a policy without a budget, it's unlawful. So this human resources policy has to have a budget. It doesn't have a budget. It's unlawful. It's useless as it stands at the moment. The Constitutional Court has also said, in relation to available resources, that government can't just say it doesn't have resources. It has to show that it has looked for resources and that it doesn't have resources. And the third thing the principle the Constitutional Court has said is that it's not good enough for the health department to say, we don't have resources in the health department. You have to show that there are no resources in government. You have to look across departments for your resources. That's the law. The problem is that we don't know the law. So when some government bureaucrat says there's no resources at a provincial level, we're finished. We can't take the argument any further. And that's the problem. Because our country, because it is resource constrained in some ways, has to have a debate about resource utilization and where resources can be obtained from. So for example, I think it's a problem that we spend 2.6 billion rand 2 years ago, at least, on VIP protection, 2.6 on blue lights, 2.6 billion rand a year. We need to take things like that to ordinary people and say, do you think that all of our MECs should be having a phalanx of police cars and so on? Yeah, if you don't have the essentials. And you can repeat that debate on many levels. We also, as activists, have to start saying, the pie is this big, but why aren't you making the pie bigger for resources? We've debated in this country, why is it that there's never been a wealth tax created? Government is scared of rich people and the elites of this country. But we're not proposing to take all of their wealth away. We're proposing that if you had, for example, a 5% wealth tax, you could raise hundreds of billions of rands. It wouldn't do them any harm. They're not all going to go and run to another country. And then you would have resources to play with. So I'm just making these points, Paul, because the resource argument shouldn't defeat us. And the other point is that we have to show that spending money because it's a right saves money. It's not just a drain constantly. If you had effective community healthcare workers, you would prevent TB and the cost of TB. You would prevent diabetes and the cost of diabetes. You would prevent a whole series of costs further down in the health system. So that's the resources issue. On what Kate on data, I can only agree, but the question is, what do we do? What do we put forward? Where are the data gaps? And how do we say that these data gaps are filled? And who do we tell to fill the data gaps, and why? And, if it's on something like disability, and this has to be a theme of everything, we have to be inclusive as activists of the people who are affected. So let people with disabilities also speak about why there's a need for data about their lives as people with disabilities, because you can't advance their right to equal treatment if you can't describe the discrimination that they're experiencing in the first instance. Desmond, unfortunately, your example of SANAC is not a good example. I was the person who resuscitated SANAC in 2007. And it worked for about 5 or 6 years. And the principle is right. But then it got hijacked. And what happened was that SANAC became something where people tried to reach agreement on the lowest common denominator on everything. And that can't be the basis. And then within civil society, people saw it as a place where you could go and get comfortable next to the Minister of Health and the President and so on. And so it's become a problem. But your point about health governance is absolutely right. And we have the model. The National Health Act says, sorry, Madeline, I'm almost done, says that there must be national health consultative forums. It says there must be provincial health consultative forums. That's a SANAC. That's a something where health practitioners should sit with government bureaucrats, should sit with communities, et cetera, and engage each other on the realities of the health system. There hasn't been a national health consultative forum for about 2.5 years or 3 years. In the middle of the biggest health crisis we've ever had, we're not talking to each other. So why aren't we saying to the DG, who's just been suspended this afternoon, that we need a national health consultative forum and pull it together? And your point about clinic committees and hospital boards, absolutely right. You know, it's not that school governing bodies are perfect, but the Education Department and the Education Act allows several days for training of school governing bodies about their functions. But with clinic committees, they're just meant to be elected. All sorts of people get elected. Sometimes people get elected for the wrong reasons because they think we can get close to resources, to tenders, etc. But health governance is going to be crucial, but it has to be linked to training and to ownership of the health system so that the people there become supporters to the people who are within the health system. I know I'm out of time. I just want to touch two last things. Steve Reed. Steve, how do you prioritize? I don't know where we prioritize. That's what I'm challenging all of you with. Where do you prioritize? I don't think you need a list of 100 things as an activist, because then you don't know where to start. So what I'm saying is discuss what are the game changers? What are the game changers that, as Victor said, everybody speaks with the same voice on the few game changer issues. But in the meantime, in your own back garden, you're working on rural rehab and disability, you're working on whatever is your particular issue. But what are the issues that need to happen? Because we know that if the human resource plan is taken seriously, it'll be the biggest game changer on rural equity of anything. Even if you only get 40% implementation of this thing, it's a hell of a lot better than 0% implementation, which is what we're going to get on that at the moment. And it links to Victor's point, you know, in this day and age, if you're a human being, you have to be an activist, frankly, because if you don't take control of your own environment and your space, not on behalf of yourself, but on behalf of communities and everybody, then we're going to be flattened in what lies ahead in our lives. So we have to encourage, but we mustn't discourage people by thinking that means you have to be 24 hours a day activists. There's small things, and lots of people are doing the small things. You know, I'm seeing it in communities, people setting up food gardens, people setting up alternative food systems. There's been an incredible thing going on underneath in COVID. But our problem as activists is that health activists have talked over the heads of ordinary people on COVID up to this point. There's no COVID literacy. There's no going down to community levels, working with people. There's no data. Who's dying of COVID? We don't, of that 250,000 people, how many are in rural areas? Why did they die? How many people died because they didn't get a ventilator, because they didn't get this and this and this and this and this? You know, I'm not singing tax praises because I was involved in it. It had nothing to do with me, but tax set a model for you go into the people who are affected by ill health, who are vulnerable to ill health, and you build power there rather than talking at an elite level, which is what we all do on Zoom conversations, etc., arguing with each other and leaving people out of the equation. COVID is going to be here for a long time, so it's not too late. We're not getting to the end of COVID. There's a lot of COVID left, one way or another. And the last thing I just want to say, sorry, Madeline, is, I mean, Russell, you're right. The private sector, and I left it out of my presentation, there are multiple levels of inequality. multiple drivers of inequality, and the private healthcare sector is one of those. Absolutely. Government has to use its power to regulate the private healthcare sector. Government is allowed to intervene in markets. We saw it with ARVs. Government intervened to fix prices of ARVs so that they could be affordable to the public healthcare sector. That principle applies to every aspect of healthcare. But the problem is that government needs to be pushed to do that. These issues need to be put in people's faces so they become moral questions with the solutions put side by side in front of government for government to act. I honestly, Russell, but we can debate this outside, don't think that the problem is with the Constitution. I'm not saying the Constitution is it is faultless, or with limitations of a rights-based framework. The question is, how do you use the rights-based framework? What does activism do? You're absolutely right. We can't just say section 27, section 27, section 27. It's practically, what does section 27 combined with section 28, etc., actually mean? I mean, I think I'll finish on this point, and because it's a rural health issue as well. But it's an indictment of all of us as activists that 25 years after this constitution, nobody is talking about children's health and saying that children have this right that is immediately realizable to a certain minimum quality of basic healthcare services. We haven't even defined what basic health, these words, basic healthcare services. We haven't even got a definition. You as the doctors haven't given us a definition that say basic healthcare services for children must include 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. You can't use the law and use the constitution. It's like Kate's point about data. If you haven't created a definition of a legal right, how can you fight for that legal right? If you haven't held out to ordinary people in the rural areas where you work, that your children have a right in our constitution to these things as of now, start fighting for them, then you can't blame people for not knowing that there's a tangible right that can make a difference to their lives. So I stop, but I'm just really trying to throw these things for us to debate as we go forward. Thanks.
Thank you very much. The good news is, this is not the end of this discussion. Okay, so this is the start of the discussion. And I want to point out tomorrow morning at 10:30 in venue D, Russell will be